Namaskar, dear viewers. Welcome to today's webinar of Young India Intensivist. And at the outset, I would like to thank very much Professor Chiumello sir for taking this second session also now, which he himself has volunteered to teach us. And I'm really thankful to him. And many of you attended his last talk on lung mechanics in ARDS, and subsequently you have seen on the channel also, YouTube channel. So I'm really thankful to you, sir. And Dr. Chiumello will be taking a third session in September on mechanical ventilation from bedside to artificial intelligence, which is really one of the hot topics now and will be very useful. And not to say the least about non-invasive ventilation, which is today's topic. It is a paramount topic, in terms of importance. Non-invasive ventilation, we all know, we use it all the time. So I think Dr. Chiumello is one of the experts on this because his area of research has been respiratory critical care. He has authored more than 500 articles and published guidelines, protocols, etc. in respiratory critical care. And just to introduce him again, he is Director, Department of Anesthesia and Intensive Care, AST Santi Paolo e Carlo, Milan, Italy. And he has been the former editor-in-chief of the very prestigious journal Minerva Anesthesiologica. So thank you, sir. Thank you very much for the teaching on our platform. It is really a big help to so many young students and intensivists all over the world. Thank you very much, sir.
Thank you very much, my friend Tapesh. Good evening. It's a good pleasure to be again with you. Today we will speak and revise some topics regarding non-invasive ventilation, starting from some pathophysiology aspect, then clinical application, and a short summary regarding the guideline. So first of all, what are the force and the pressure that are usually present every time we breathe or we use mechanical ventilation or non-invasive ventilation? So we have two types of pressure. The muscular pressure, which is the pressure generated by the patient himself, by the movement of the diaphragm, and the pressure developed in this case by mechanical ventilation. Every time there is a ventilator, both invasive and non-invasive, this kind of pressure sum with the pressure generated by the patient to generate the total inspiratory pressure. And why it is important to, to have an idea regarding how this pressure is used to inflate the respiratory system, so to generate a certain amount of tidal volume depending on the respiratory mechanics. So in this case, elastance of the respiratory system. Other part of the pressure is the pressure to overcome the resistance, and in some case, especially for example in COPD patient, in which there is a certain amount of intrinsic PEEP, this pressure is generated to overcome the intrinsic PEEP. So by moving from this basic concept, now I would like to speak a little more regarding the elastic and the resistant work of breathing. Here is a clear example in the upper part, like a pressure volume curve. There is in the healthy condition, so there is a certain amount of pressure to generate a certain amount of volume. By moving from healthy condition to sick condition in the lower part, to generate the same amount of tidal volume, so the same inflation, the patient has to generate a higher amount of pressure. And this is clear show in the figure because there is a reduction, there is a moving of the pressure volume curve in the lower part. So same tidal volume, higher pressure is required. Second part is the resistance. As you can see, Again, in the upper part, healthy patient, lower part, sick patient. During inspiration, in normal condition, during a dynamic inflation, this pressure is used to overcome the resistance, plus the static condition of the respiratory system, as we told before. But in presence of an increase in resistance, typical, for example, status asthmaticus, we have to generate a higher amount of pressure, which is spent not to inflate the lung, but to overcome the resistance. So this is clear example. Whenever we treat patient with invasive and non-invasive ventilation, we have to understand which is the main problem. Is the problem the elastance or compliance, or problem of resistance? Because as you can see, maybe we can have to recruit the lung to improve the PEEP, to improve the respiratory system elastance. If there is a problem of inspiratory resistance, maybe we have to use steroid bronchodilators. Whenever we increase the PEEP, this is a typical pressure volume curve, we increase the starting volume. So not the FRC. The FRC is the end expiratory lung volume at zip. By increasing PEEP, we move to this curve, so we increase the starting volume. But if we increase too much, for example, the PEEP, we move during this line, and if we are in this position in the upper part of the curve, for the same amount of pressure, we have a reduction of tidal volume. This is typically due to overstretching the lung. On the contrary, if the compliance change by increasing PEEP, we can obtain the same tidal volume with a lower pressure. This is usually whenever we apply CPAP. So CPAP is able to reduce the work of breathing if improve the compliance. So for the same tidal volume is required lower amount of pressure. What's happening during non-invasive mechanical ventilation? Look this figure in the right part. We have a patient with very active tachypnoic, dyspnoic. So he is able to generate a very high inspiratory effort, which translates in a very negative pleural pressure. For example, minus 15 centimeters of water. Remember that in healthy condition, the pleural pressure during inspiration range between -2, -4, -6. We have here -15, so a very strong inspiratory effort. So we use non-invasive ventilation with the pressure support, for example, of 10 centimeters of water. The pressure which distends the lung is not only the pressure generated by mechanical ventilation. Physician set in this case a pressure support of 10. The total pressure which distends the respiratory system is the pressure inside the lung, in this case 10, minus 15. So at the end, we obtain transpulmonary pressure of 25. This is very high transpulmonary pressure. This pressure can be present during invasive mechanical ventilation in well-sedated and paralyzed patient in very sick condition. So what does it mean, my friend? That you can reach the same transpulmonary pressure, the same stress, the same injury by ventilator patient with acute respiratory failure with invasive mechanical ventilation and with non-invasive mechanical ventilation. So it's really wrong state that non-invasive ventilation is safer compared to invasive mechanical ventilation, depend on the condition which are generated in the patient. So what we have to do every time we admit a patient with lung injury, there is an increase in lung permeability, there is a capillary leak, there is an increase in the weight, increase in the lung edema, collapse, atelectasis, impairment of gas exchange, hypoxemia, reduction on CO2 clearance. So the patient start to have tachypnea, dyspnea. So very high respiratory effort, very high minute ventilation, very high negative pleural pressure. This can promote for sure, my friend, a sort of ventilation-induced lung injury that is called PSILI, patient self-inflicted lung injury. It's not, in this case, the ventilator, like during invasive mechanical ventilation. This is mainly due to the patient. And if the physician, when use non-invasive ventilation, is not able to reduce the transpulmonary pressure, we are not doing a good job for the patient because the transpulmonary pressure reflects a short amount of injury. So the goals, whenever we apply non-invasive ventilation, is not only to improve gas exchange, so increase the oxygenation, reduce the CO2, is to limit as much as possible the ventilator-induced lung injury. This is another figure showing the same concept. We have a patient, spontaneous breathing, with acute hypoxemic respiratory failure. This generates a very high respiratory drive, a very high inspiratory effort. Look at the left part. This suggests a very high transpulmonary pressure, high tidal volume, high respiratory rate. But also the presence of acute respiratory failure can increase the lung inhomogeneity. So this lung inhomogeneity translates to a different transpulmonary pressure. In some part, the transpulmonary pressure is higher compared to the other part. So by putting together, this can promote the ventilator-induced lung injury, trauma, barotrauma. And because we are in active condition, patient self-inflicted lung injury. So which is the mainly cause of alteration of gas exchange in patient with acute respiratory failure? Are two different conditions. The most frequent condition is the presence of shunt, so region of the lung that are not ventilated but are still perfused, and this generates hypoxemia. Then we have a short amount of patient, typical COPD patient, for example, in which hypoxemia is not mainly due to the shunt, but is due to alteration in ventilation perfusion ratio. So we don't have to treat in the same way. in patients which are characterized by a high amount of shunt, we have to reduce the shunt. And how is possible to reduce the shunt? For example, by increasing the PEEP, by performing recruitment maneuver, by putting in prone position, by using pressure support. If you have an alteration in ventilation perfusion ratio, PEEP is not the way. Prone position is not the way. We have to just simple increase the oxygen fraction because the lung is ventilated, contrary to lung in which there is shunt. So what is non-invasive ventilation? Non-invasive ventilation belongs to a higher family, which are the non-invasive respiratory support, CPAP, high flow nasal cannula, and non-invasive ventilation. Today I mainly concentrate to non-invasive ventilation. Non-invasive ventilation is defined as a patient trigger, so there is an active effort, pressure target, typically pressure support, pressure control, in which the ventilator delivers during the inspiratory phase a certain amount of inspiratory pressure. And this amount of inspiratory pressure is above a PEEP level. So we have to select two knobs, the pressure support and the PEEP. The following slide, I will show some example of how to set up non-invasive ventilation. Non-invasive ventilation is not very simple. Here are shown typical problems that can be present in up of 40-50% of the patient. So every 2-3 patients, there is one or two patients we can have significant problem. For example, ineffective triggering, auto-triggering, delay cycle, and a certain amount of CO2 rebreathing. We have to check to see the patient. Every time we start non-invasive ventilation, at least in the first hour, we have to stay in front of the patient to see what's happened to the respiratory rate, tidal volume, minimum ventilation, saturation, CO2. Why? Because unfortunately, non-invasive ventilation is related to a certain amount of failure. Look here in red. Rate of failure in RDS patient, oh my God, can reach 40-50% of the patient. On the contrary, cardiogenic pulmonary edema, rate of failure lower than 10%. So it's very safe to use non-invasive ventilation in cardiogenic pulmonary edema compared to patients with RDS. And the most worse is community-acquired pneumonia and extrapulmonary RDS. The condition of the patient can modulate the outcome. This is the typical classification of RDS according to the PO2-FO2 ratio, so according to the mild, moderate, and severe form of RDS. This retrospective study, the use of non-ventilation was quite similar independent of the severity. But look what's happened in the orange. By increasing the severity, of RDS according to P2F2 ratio. So higher is the amount of edema, higher is the amount of hypoxemia, higher is the knee failure. Can move from 20% in the mild form up to 50% in the severe form of RDS. But it's not a problem of failure, it's a problem of outcome. Patient who fail non-invasive ventilation with and without a severe form of RDS, this, for example, population was divided with a cutoff of P2F2 ratio of 150, look the mortality compared to patient who success. The mortality was double, 4 times. So what does it mean? Means that if we decide to use and to start non-invasive ventilation, we have to remember that if the patient fail, the mortality is significantly higher. The message is not to avoid the use, but remember, if the patient fail, the outcome can be worse. So if we are in doubt, not use non-invasive ventilation. If the patient did not change after a few hours of the use of non-invasive ventilation, please stop. And if indicate, intubate, sedate, and start invasive mechanical ventilation. Another important point is when non-invasive ventilation fail. We have an early failure between 1-2 days or a late failure. And the outcome is completely different. In the early failure, the outcome is significantly better compared to patients who fail later. Why? Because in the early phase of the disease, we can, for example, change the antibiotics. We can use prone position. There is not a severe infection. Things that can be present in the late phase. What are the indications to start non-invasive ventilation? Then I will revise with you, if we have time, the most important application of non-invasive ventilation, such as acute respiratory failure, RDS, cardiogenic pulmonary edema, and COPD. First group of patients, acute respiratory failure, RDS. We have to remember, we have to start non-invasive ventilation in patients who present a respiratory rate higher than 25-30 breaths per minute, plus an impairment of gas exchange, P2F2 ratio lower than 300. Very simple criteria. If you don't have arterial blood gas analysis, use pulse oximeter. SO2, FiO2 is similar to the P2F2 ratio. When you have to apply non-invasive ventilation, according to this expert opinion, non-invasive ventilation, in yellow, was suggested not in all the form of RDS. The author here suggests to start to apply non-invasive ventilation only in the mild or at least moderate form of RDS, while in severe DS, they suggest to use invasive mechanical ventilation, PEEP, prone position, neurovascular block, blah, 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 blah. How we can deal or provide non-invasive ventilation depends of you have in your hospital. Typically, we have, look here, the total face mask. Use the face mask or the total face mask, not the oral nasal, because here, especially in patients with the acute respiratory failure, there is a leak problem. So we have to avoid as much as possible the leak. Another possible solution is the use of the helmet. The helmet can have some beneficial effect. Of course, they are more expensive, are not usable compared to the face mask, which are usable, significantly lower cost. The advantage of the helmet is that the patient can speak. There is a lower amount of air leak. There is no high irritation. There is any contact with the face. So helmet can be used for a longer period of time compared to the face mask. The disadvantage is the noise, and patients who present claustrophobia cannot use the helmet. What's happened when we use non-invasive ventilation? This is a study in which was compared the inspiratory effort, the change in esophageal pressure or the pressure time product during high flow nasal cannula, helmet CPAP, so a simple amount of PEEP, and helmet with non-invasive ventilation, so PEEP plus a short amount of pressure support. The non-invasive ventilation was able to reduce the inspiratory effort, while helmet CPAP and high-flow nasal cannula present a similar amount of work of breathing. So the message, if your goal is to improve, to reduce the work of breathing, you have to use non-invasive ventilation, so pressure support plus PEEP. What's about gas exchange? Not significantly much change regarding the PCO2, which is related to minimum ventilation and the respiratory rate. Minimum ventilation was quite similar. The size of the baby lung, so the end expiratory lung volume, so the lung gas volume, was significantly better in patients with CPAP or non-invasive ventilation compared to high-flow nasal oxygen. What we have to look, we have to avoid the failure of non-invasive ventilation. In this retrospective study, the author evaluate the possible difference of the patient at the beginning of non-invasive ventilation according to the outcome. So patient who failed NINV, patient who succeeded non-invasive ventilation. The minute ventilation was significantly higher in patient who failed non-invasive ventilation. Was around 20-21 liters per minute. Oh, huge minute ventilation. Tidal volume. Another important point is not only minute ventilation, but you have to look respiratory rated tidal volume. Tidal volume up to 10 ml per kilo. If you remember LDS, you have to use a tidal volume of 6, 7. Look here, we have a tidal volume up to 10, 11 ml per kilo. And why failed this patient? Because this high tidal volume reflects a very high inspiratory effort, a difficulty to eliminate CO2. What are the possible risks of failure? So the severity of what? Of impairment of oxygenation. When you have to look after 1, 2 hours, if there is no change in the oxygenation after 1, 2, 3 hours of application non-invasivation, please stop and think if the patient should be intubated. Then we have also the score, which are very simple. Score consider different fields, not only the oxygenation, but hemodynamics, heart rate, the acid-base equilibrium, pH, Glasgow Coma Scale, respiratory rate. For every range of this topic, there is a point. For this score, up to 7, there is not much difference. But up to 7, 8, there is a significant difference in patients who succeed non-invasive ventilation compared to patients who fail on non-invasive ventilation. The other variable parameter that we have at this side, respiratory rate we already spoke, tidal volume we already spoke. This ratio, saturation according to the oxygen fraction. So not blood gas exchange, just pulse oximeter. There is an optimal setup, maybe not. There is a certain guideline, there is a sort of suggestion, because you have to titrate according to the condition of the patient. However, just to give some idea, some range, PEEP, no more than 8. I suggest a mechanical ventilator coming from the ICU to humidify the gas, which are the target. Respiratory rate lower than 25, 24. Tidal volume between 6 and 8. Pressure support to reach this certain amount of respiratory rate and tidal volume. Saturation, in my idea, between 92 and 94. Helmet. If you are going to use the helmet, please remember, due to the elasticity of the helmet, you have to use a high amount of pressure compared to the face mask. What does it mean? I have a patient with face mask. I want to change the device. I have to increase the level of pressure support. This is very important. Otherwise, the inspiratory effort for the same inspiratory pressure will increase. So we'll start fatigue and the worst outcome. Is useful non-invasive ventilation delivered by helmet compared to face mask. This is quite recent meta-analysis seems to suggest that patients treated with NIV have a significantly better outcome compared to patients with face mask. Another important point, where to monitor the patient. I suggest to use non-invasive ventilation outside intensive care. It is possible, but you have to a close monitoring setup. Which variable? The variable that we already see in the previous slide. CO2, saturation, tidal volume, respiratory rate, minimum ventilation. The problem is that we use helmet. We don't have tidal volume, minimum ventilation. We just have a respiratory rate that, of course, is better than nothing. But the respiratory rate sometimes is not associated to minimum ventilation. There is no correlation. So by looking only respiratory rate, we forgot an important aspect, which is the minimum ventilation. Okay. The score, if you like the score, please use. There are several scores. I just suggest to use the ACA score, which is validate in patient treated with non-invasive ventilation with face mask. And also another important point, which is not considered in the ACA score, is the CO2. If the CO2 remain lower, does not increase, or at the opposite, decrease during non-invasive ventilation, please pay attention that this is associated to a worse outcome. So patient is in trouble if he's not able to ameliorate the CO2. Why? Because it remains a difficult to CO2 elimination. So here require very high minimum ventilation, very high inspiratory effort. Prognostic factor. There are several. I just summarize the severity of impairment of gas exchange, the tidal volume, the hemodynamics, the presence of acidosis, heart rate, a decrease in pressure. So are all consideration that you have to use and to remember whenever you use non-invasive ventilation. What you have to do in this condition? First, there is a very high respiratory rate, or there is not a reduction but an increasing step by step. This suggests a very high drive. This suggests agitation. This suggests lung inflammation, anxiety. How we can deal? We can increase the pressure support with or without increase of PEEP. Never decrease the pressure support of PEEP if the patient remains tachypnoic, dyspnoic. High tidal volume, high effort. My suggestion is to try to increase the pressure support, the PEEP, to increase the size of the baby lung. In presence of impairment of oxygenation, as we spoke at the beginning, the only way that we have is to increase the PEEP and then to put in prone position. A reduction in PCO2 is associated to a worse outcome. Coming to the end of the first topic, what are the clinical guidelines? Should non-invasive ventilation be used in patients with de novo acute respiratory failure? In this guideline, the authors were unable to offer a clear recommendation on the use of non-invasive ventilation. Why? Because there are several data suggesting the non-invasive ventilation is able to reduce the intubation, but is not able to affect the outcome. Second part, patient with acute pulmonary edema, patient with acute heart failure. There are difficult conditions, different clinical setup in patients with acute heart failure. There is the presence of acute heart failure with COPD. There is acute pulmonary edema. There is cardiogenic shock, or there is isolated right ventricular failure. The role of non-invasive ventilation is not in all conditions of heart failure. The typical conditions are the cardiogenic shock and the heart failure with or without COPD. Acute pulmonary edema, in my opinion, does not require non-invasive ventilation. Just require a certain amount of PEEP to improve gas exchange to reduce the floating of the water from the lung. So what suggests the guideline regarding the use of non-invasive ventilation in present cardiogenic pulmonary edema and acute respiratory failure? The problem is that several trials have excluded patients. Some of them also exclude ischemic heart failure. So there is a great heterogeneity of the patient. However, there are a certain amount, huge amount of bibliography and the author and guidelines that recommend the use of non-invasive ventilation during acute respiratory failure due to a cardiogenic pulmonary edema. So I have just few minutes, just few words regarding the use of non-invasive ventilation in COPD. When and why? This is a typical criteria. pH lower than 7.35 associated with PCO2 higher than 80, 90, and respiratory rate higher than 24, 25. How change our practice in treat COPD patient? This was the amount of patient with a lower pH treated with COPD, treated outside intensive care. And look here, during the year, there is a significant amount of patients which present a high severity that were treated outside. But how is the outcome? Because, of course, according to this data, more patients are treated outside, but the outcome was better, worse, or didn't change. Starting from 2010, 2013, the median initial pH to start non-invasive ventilation significantly decreased from 7.3 lower than 7.24. Huge reduction. And fortunately, this reduction in the pH, so this increase in the severity on the acid-base equilibrium, did not affect the outcome. The outcome remained stable. Around 10% of the patient died. COPD patient should be applied with pSO2 higher than 45, 50, with the pH lower than 7.35. So don't use only the pCO2 to start the non-invasive ventilation. And there is no limits of pH below which non-invasive ventilation is contraindicated. However, we have to remind that higher is the severity of the acidemia due to respiratory acidosis, worse should be the outcome. The setup in this case can be slightly different compared to acute respiratory failure. We have to set the PEEP enough to overcome the intrinsic PEEP and the pressure support to generate a tidal volume up to, my opinion, 8, 9 ml per kilo. So the problem is not the ventilation-induced lung injury. I suggest to use pressure support or pressure control. Both of them are effective, but remember, only ventilator created, designated to deliver non-invasive ventilation should be used. The interface, we already spoke. Use whatever interface that you like. However, remember that the outcome can be significantly different. If you have a very acidemic patient, in my opinion, it's difficult to start with a helmet CPAP because a helmet CPAP can have a problem of CO2 rebreathing and can be a problem in order to reduce the work of breathing. Regarding COPD, there are several clinical conditions in which the outcome can be worse. For example, patients with pulmonary fibrosis and isolated pneumonia have a significantly worse outcome compared to acute reactivation of COPD. The patient, the body mass index, the level of acidemia, the level of CO2. So what they suggest, the guideline, non-invasive ventilation should be used to improve the pH, not only to reduce pCO2, but to, again, to improve the pH. there is no sense to use non-invasive ventilation in patients who are not acidotic. So please look the pH. And again, they suggest to use non-invasive ventilation in patients with acute or chronic respiratory acidosis, pH lower than 7.35.
Yeah. Thanks, Dr. Chiumello, sir. Very nicely put out for all of us. And may I just request you, yeah. So,
Yes,
so thank you very much, sir. Very nice, elaborated, and
my pleasure.
yeah. So, sir, I request the audience if they have any questions, please type your questions. Professor Chiumello will be happy to answer. So, sir, while we wait for any questions, maybe I can just put up some points for discussion for everybody's interest. So, sir, one of the really interesting features of NIV use over the years has been that it has not been shown to reduce mortality in acute de novo hypoxemic respiratory failure, but
Yeah.
it reduces intubation rates. That is what we.
Yes,
So
yes.
would it not be that if it reduces intubation rates, it should lead to reduced mortality? But should it not be like that? What is the problem here?
I suggest if the condition of the patient permits, so not severe impairment of gas exchange, Q2, FO2 lower than 100, I not suggest to use non-invasive ventilation. I suggest and promote the application of non-invasive ventilation in RDS patient with mild and moderate severe form, and to check in the first 12, 24 hours the variable that I show. Not only the oxygenation, but the CO2, tidal volume, respiratory rate, hemodynamics, and Glasgow Coma Scale. If the patient remain, for example, severe tachypneic, impairment of the Glasgow Coma Scale, or hemodynamic impairment, don't waste time, stop non-invasive ventilation, and start invasive mechanical ventilation.
Yeah. So actually, sir, what I was asking was about the difference in the reduction in the intubation rates, but no difference in mortality with NIV. Right. That is what the evidence shows, the meta-analysis, that when you use NIV, you have a reduction in the intubation rate, but
Yeah,
but the mortality does not reduce. Right, sir?
no,
So if the
right.
intubation rate is reducing, the mortality should reduce, but it is not like that. So how do we explain this?
Yes, good question, my friend, because maybe there is a delay, okay? The problem is when you start invasive mechanical ventilation. If you start invasive mechanical ventilation too late, maybe the PSILI is already happened, was already done. So this can be a possible solution. Other solution, as you know, you intubate the patient, you can have several negative effects. So, for example, lung infection, impairment of hemodynamics, impairment of kidney function, and so on. So, these are the possible explanation for not relationship, good relationship between the intubation and the mortality.
Thank you, sir. for the answer. Yes, I think that explains the contradiction here. So moving on to helmets, you mentioned briefly about helmet. So,
Yes.
so what is the current status of helmet in NIV? What do you recommend for helmet?
I don't recommend the use of helmet for non-invasive ventilation because it's very difficult to use. The helmet seems a good interface to deliver CPAP. But if you have a patient, for example, with very high respiratory rate, tachypnoic, it's difficult to have a good interaction between the ventilator and the subject. Because as you know, the ventilator starts to inflate the patient when there is a negative pressure. When the ventilator recognizes an inspiratory effort. Then the ventilator starts to give flow. But there is a delay to pressurize the helmet. And this can cause the maintenance of a very high inspiratory effort for almost all the inspiratory phase.
Right. Thank you for the answer, sir. So then, for a PF less than let's 150 to 100, we don't recommend mask NIV. But what about high flow nasal cannula? Is it okay to use high flow nasal cannula if PF is low, let's say like less than 150? Is it better than intubating?
Another good question, my friend. Why do you always speak about PFR2 ratio? I would like to forget the PO2 FR2 ratio because it's just one side of the moon. I would like to see the PCO2. I would like to see the minimum ventilation. I would like to evaluate the inspirator effort. If you don't have an esophageal balloon, for example, you can evaluate the change in the central venous pressure, the activity of the muscle. This can suggest a very high inspiratory effort. I have several data that in patients with severe inspiratory effort or work of breathing, the high flow nasal cannula is able to reduce in a safe way.
Thank you, sir. Sir, then moving on to the next point about borderline hypoxemic respiratory failure, early stage patient has come to the ICU. Saturation is 90%, 89, 88% on room air. Borderline kind of a patient. So is it okay to just put oxygen by nasal prongs or face mask, or should we give a device, supportive device? Does it make a difference?
I suggest in every patient who comes in intensive care or in emergency department to make a picture to standardize the history of the patient. So with poor oxygen, high flow oxygen, or with high flow nasal cannula, or with CPAP. CPAP is very simple. You need facial mask, a certain amount of flow between 20, 30 of oxygen 100% and the valve. I suggest to make a photo of this patient. And then, according to the data that you get, you can decide the optimal non-invasive ventilatory strategy for this patient.
Right, sir. Thank you, sir. So then next point, sir, if you can throw some light on this. So when we put the patient on face NIV, face mask NIV, and we monitor the patient, one of the strong indicators for failure of face mask NIV is the high expiratory tidal volume, which is more than 9 ml per kg of the body weight. But the question here is most of the patients on this face mask NIV have leaks. So when they have leaks, you do not know the expiratory tidal volume. So what is the point in talking about this expiratory tidal volume?
I completely agree. If you have leak, this all these core are quite questionable. So before to perform a score, you should reduce as much as possible the air leak. Otherwise, in addition to not to the possible unreliable data according to this score, the effect of, for example, pressure support is not good because all the pressure disappear, is dissipated outside, not inside the patient. One possible advantage with the helmet, you can reduce the air leaks. But again, you have a problem with synchrony, delay. So air leaks is a huge problem. Can be in some patients a huge problem. For
Yeah.
example, in obese patient, in elderly patient with the edentulus, can be a very huge problem, my friend.
Thank you, sir. So just the last point, sir, something which is new coming up is the development of asymmetric prongs for nasal cannula, high flow nasal cannula, asymmetric prongs, nasal prongs for high flow nasal cannula. So what is the theory and where is it going? Can you tell us a little about it?
Yeah, this was an idea that comes several ago, but there is one or two paper that suggest this form of use of high flow nasal cannula, but there are no data. So I don't believe too much.
Uh, Thank you, sir. Thank you, Professor Chiumello, sir. Thank you very much. Lovely hearing you talk and educating all of us. And we look forward to your next talk in September. Thank you very much, sir. Ciao, sir.
Bye bye. Ciao, my friend.
I thank the audience for their patient hearing. Thank you, everybody. Good night.